give them a minute or two more and we'll get started. Thank you for your patience. I'd like to go ahead and get started. My name is Lucy Savitz, and I work at Intermountain Healthcare, and I am the program director for the Intermountain-led Hospital Engagement Network. And it's my great pleasure and honor to welcome you being a part of our Hospital Engagement Network. We're very much looking forward to working with you. What we'd like to do on the call today is to get you oriented so everybody's on an even playing field and talk about next steps in terms of our learning journey and how we're going to move forward. Next slide, please. As you saw on the first slide, our real sort of ethos or philosophy moving forward is all teach, all learn. And so this is not just about one system or several systems telling people what's the best thing to do. We're going to learn together. But again, in starting at an even playing field, I've put up the Institute of Medicine definition for quality in healthcare. And you can scan that definition, but basically it's that we're trying to increase the likelihood of desired health outcomes that are consistent with our current professional knowledge. Next slide, please. And as many of you know, I'm sure have read the Institute of Medicine report that came out in 1999 to Err is Human. It was reported at that time that there were between 44 and 98,000 deaths attributable to healthcare. These were avoidable adverse events, and many, many more that did not actually result in death of our patient populations. Next slide, please. But we do know in hospitals today that despite years of research and practice-based improvement efforts, the number of patients actually harmed in our hospitals is probably at least 10 times greater than was originally estimated in that To Err is Human report. And we know from more current statistics that any of us has a 1 in 3 chance of having an adverse event when we're admitted to the hospital. And of those adverse events, there's a 1 in 6 chance that we will require extended care. Next slide, please. Thus, we've created a platform, a burning platform for change and an immediacy and urgency to move forward. Next slide, please. So on March 23rd, 2010, President Obama signed into law the Affordable Care Act, and part of the Affordable Care Act created the Center for Medicare and Medicaid Innovation as part of the Center for Medicare and Medicaid Services, or CMS. The major initiative that's come out of CMMI over the past year is something called Partnership for Patients, and it's that initiative that brings us together today. Next slide, please. So basically, we've got a historic opportunity. We've all been working on these things for a long time. We've been trying to make care safer, care of higher quality in our organizations, and we have many success stories to share, but at the same time, we've got much improvement to do. So we're being asked to take on something hard and now do it right. This is a real opportunity for us to come together and create a new standard of living, making the world a better place for all of us in terms of the work that we do in providing safe healthcare delivery to our patients, and in terms of the care that our patient populations and family members and ourselves receive in those facilities. Next slide, please. So the Partnership for Patients laid out 2 very audacious goals, and they're summarized on this slide. So basically, by the end of 2013, the goal is to decrease by 40% hospital-acquired conditions. And by end of 2013, to reduce by 20% unnecessary readmissions to the hospital. And you see documented on this slide the estimates in terms of the fewer injuries and preventable complications requiring rehospitalization that are estimated by CMS. And this could have a major substantial impact on, again, our patient populations. Next slide, please. The 10 areas that Partnership for Patients has identified as initial targets are listed here. So again, you won't see anything new, you won't see anything earth-shattering that you haven't seen before. And one of the first priorities that I'll talk about a little bit more detail in a moment is obstetrical trauma. Next slide, please. So what do we know? We know that major improvement is possible. The science is clear, and in many of these areas, it's been clear for quite some time. Again, many of us have already done it, and most of us have at least begun working in these areas of patient safety, and many of us for a very long time. It's fairly straightforward to start working on this and achieve big results. The measurement is doable, and feedback reports will help show progress that we've made. And then all of us can really learn as much from actually doing this work and sharing this work with each other than sitting sort of myopically in our own delivery systems, our own hospitals, and working on it in a solo fashion. Next slide, please. The model learning delivery systems that were really brought together to harvest best-in-class practices around these 10 areas are listed here. So this is not Intermountain alone. Intermountain just really did sort of the heavy lifting on the proposal, and we're responsible for the organization and delivery of the content. What you see in parentheses after each healthcare delivery system is that patient safety area that delivery system is serving as the primary subject matter expert. So you see Baylor Healthcare, Dartmouth-Hitchcock, Denver Health, Intermountain, Mayo Clinic, Providence Health and Services, and the Salt Lake City VA Medical Center. Next slide, please. These systems have a very long history of collaboration with established trust, and we've been doing many, many applied health services research projects focusing on patient safety and quality improvement for over 2 decades. Next slide, please. Next slide, please. Perfect, stop there. So a number of these partner systems, with the exception of the Salt Lake City VA Medical Center, have come together in something called the High Value Healthcare Collaborative. And these are delivery systems that have really acknowledged that we can't wait for the federal government. We need to move forward, and we need to bring to the fore solutions and models that work, allowing us to achieve our mission-critical aims of performance excellence and efficiency in healthcare delivery, as well as surviving in the current climate with impending payment cuts. We're being asked to do more with less, basically, and it's a challenge we all face. Outside of the delivery system partners that are the principals in this initiative, a number of our other partners who are joining on the call today and joining in the learning journey with us, like Scott and White, for example, like Sutter Healthcare System. I'm not going to name them all right now, but you are equally involved and committed to the dream team, basically, in the High Value Healthcare Collaborative. And so it's another way and another mechanism for us to come together. Next slide, please. These are just some examples of safety accomplishments that have been achieved by some of our partner systems. You can see major reductions in ADE, sepsis, and deep wound SSIs at Intermountain, reductions in 30-day adjusted readmissions at Baylor Healthcare for heart failure patients, 100% CLABSI incidence reduction over a 10-month period at Dartmouth-Hitchcock, and numbers of patients diagnosed with VTE, PE within 48 hours of admission were reduced by 50% at Mayo Clinic. So these are just, again, a couple of examples of progress that have been made to show what is possible, what can be done, and these are the kinds of initiatives that we will be documenting and providing resources and technical assistance to you to continue to work on these issues in your own hospitals. Next slide, please. Now, to give you some context, the Centers for Medicare and Medicaid Innovation, or CMMI, under the Partnership for Patients, awarded 26 hospital engagement networks, and the Intermountain-led HEN, as they're calling it, is actually one of those 26. And it's really the central feature of the entire improvement process aimed at accomplishing those two audacious goals of 40% reduction in healthcare acquired conditions and 20% reduction in unnecessary readmissions. And the vital role that you as participating hospitals and providers play in achieving that goal is really front and center to the entire initiative. So you really are leading the way, and I want to commend you for your willingness to commit and work on that. Next slide, please. This is the distribution of the 100 pledged hospitals, and that number is growing. I will tell you that there was a lot of chaos in the field. When the proposals were originally submitted in July of 2011, many proposal authors received commitment letters. Some of those proposals were awarded, some of those were not. So for the unawarded proposals, there were hospitals that were left without a partner. And then when the short list was announced of the 26 HENs, some leadership in some delivery systems and hospitals thought, well, maybe we have a decision point here and we can see who was awarded and make a decision. So there was great chaos in the field that ensued. But I can tell you that right now, with the 100 pledged hospitals we have representation in all 4 U.S. Census regions. Next slide, please. And this is the current distribution of the pledged hospitals around the United States. And you can see at a certain level that the hospitals are located across the full urban-rural continuum. There are 15 states that are represented. And Jason Scott just informed me that we're going to be picking up a number of hospitals in the Midwest area, so that sort of blank area in the middle of the country will be more populated once we get an updated list. Next slide, please. So what is available? There will be monthly webinars. There will be a website of resources, and we'll give you that address at the very end of this particular webinar and allow time for questions and answers here today now. There will be continuing education credit for completion of the training materials. There will be technical assistance as you implement. There will basically be a community of like-minded improvement experts across all of your hospitals that are represented. And we will look to be sharing stories of success and lessons learned, not just in the 7 partner delivery systems that are sort of leading the effort, but across all of you, because we know all of you have done good, important things, and we're going to look to highlight those things. There's a great deal of interest in Washington to provide success stories so that we can really show the nation and help create and garner and sustain the enthusiasm for change that we've put in place. Next slide, please. This is the hospital pledge form that may or may not look familiar to you. We were asking each hospital to pledge and identify a primary contact name with their phone number and their email address information, as well as the hospital name and provider number. This was used to generate a list that we were required to report to CMS. Now, a couple things I would like to just pause on here so that we can have good and complete communication. We will be sending out an email after this call with the slides from the call today, and we will be asking you to please provide an alternative contact person. So in the event that, you know, goodness, you may go on vacation or may take a day off, and if we would need to contact you, that there would be somebody else in your organization who could be sure to help spread the word and make the necessary contacts. Next slide, please. So we've been hitting the ground running. It may not feel like there's been a lot of activity from your end, but there's been a lot of activity on our end getting set up. We were basically awarded on December 9th and told that we needed to be at a meeting in Baltimore the 12th through the 14th of December. And then obviously there were the holidays that some of us observed with our families and friends. We were asked to put together a webinar to support the Strong Start initiative with a partner hospital engagement network led by Ascension Health on January 13th. And so we were very furiously trying to hit the ground running while at the same time we were recruiting and finalizing pledges with our hospital partners. We then launched an internal team meeting with our subject matter experts that was held here at Intermountain Healthcare on the 17th and 18th of January. We did a press conference with regional representatives from CMS, SAMHSA, HRSA, Public Health here in Salt Lake City. And then we're here now today on this launch call to sort of bring you up to speed, let you know where we're at, let you know what to expect, how to be engaged, and how we're going to move forward. Our first topical webinar will address the topic of early inductions and basically reduction of unnecessary early inductions. And there will be CME and CEU offered. That will be held on April 2nd at this same time, and there will be a separate email that will come to you with the logon information. And then our first in-person meeting, which is optional, will cover the improvement building blocks, and I'll give you a little more detail on that. It will be held here at Intermountain Healthcare on May 17th and 18th, beginning on the 17th at 1 p.m. and ending at 3 p.m. on the 18th. Next slide, please. So we recognize that organizations have different levels of organizational energy. And initially, CMS was saying everybody has to do all 10 and all 10 at the same time and all 10 immediately in addressing those 10 adverse event target areas. And we know that, you have other things going on in your organization. Some people are implementing new electronic health records. Many people are trying to address meaningful use. There may be other things going on in your local communities, other rival activities that are draining energy from your organization. And what we want to be sure is that what we do well and we do right. And that's really of a paramount importance to us. So what we've tried to do is to create a flexible learning environment for you to best meet your needs on this learning journey, and at the same time to help you be activated as much as possible in all 10 of the areas. So the 3 learning levels are active learning. Active learners is the first level. And basically, the expectation of the active learners is that you will commit to send at least 1 or 2 persons to the in-person meeting here in Salt Lake City, Utah on May 17th and 18th. The active learners are required to support measures, and I'll talk about measures in a minute, and they will be eligible for technical assistance. The real-time learners have access to full enduring material. So if you can't be at the May 17th and 18th meeting, or if you can't attend any one of the webinars in person real time, all of these materials will be cataloged and stored on our website and accessible for viewing by you, by other members of your team at your hospital on an as-needed basis at your convenience. You're also eligible for technical assistance. The one thing I will point out is that for those people coming to Salt Lake City to attend the in-person meeting, that travel is at your expense. And that's actually intentional, and let me explain why. Brent James, my boss, who's been doing quality improvement training and has trained over 2,000 people worldwide in quality improvement, has learned since the early days of the training, which started in 1990 here in Salt Lake City, that if you don't have really any skin in the game, is the terminology that he uses, that people really don't pay attention. They just show up, they work on their BlackBerries or their email, during the meeting. It's easy to call off the meeting at the last minute to step out, and that when people really sort of pony up resources to attend, even if they are more nominal resources, that they actually are fully engaged when they do attend. And so that was by design that we did it that way. Nevertheless, the continuing medical education or continuing education credits will be offered at no cost to you, and we can provide those credits to up to 10 people for any of the learning events. So we've budgeted a fair amount of money to provide those continuing education credits. Those hospitals that submit measured data will receive comparative feedback reports, and again, I'll talk about the measurement in more detail in a minute. Real-time learners are not required to submit measures. It's on a voluntary basis, but we will be encouraging you to submit measures as much as possible. Passive learners aren't required to commit to any of the safety areas. They don't have to report measures but they don't receive technical assistance and they don't earn continuing medical education or continuing education credit units. Nevertheless, they'll have access to all enduring materials that are on the website. We're not having password-protected websites, so really anybody can get on and have access to that information. The other thing that I'd like you to think about when you think about your organizational energy and your ability to commit is that you might say, well, for 2 of these areas, we've really done these. We're down to 0 on these. Maybe we'll take passive learning on those 2 because we're done. But we want to just keep and monitor what other people are doing, because maybe they're doing something that we haven't done, or maybe there's a unique solution that we hadn't really thought about. And so it's a way to monitor what's going on. Or perhaps you're not ready. You can't address those issues at this particular time. Or maybe it's not a big problem or a strategic priority in your organization. So that may be a reason that for some subset of the 10, you would choose passive learning. You may choose more active learning for those areas that are high strategic priority to your organization, where you know you have a real need to improve, and these are really important to your organization. So what I'm trying to say is you don't have to commit to all 10 at the same level, and it doesn't have to be a one-time commitment. You might decide, we can't deal with these 4 things right now. We can only deal with 6 things, and that at some later date when strategic priorities shift or we have more time and energy, we could add on the other 2. So I'd like you to think about it as flexibly as possible and help it fit into your organization given your capacity and your priorities. And I'm happy to answer any questions you have as you sort of ponder this and think through. And there'll be 2 ways to be able to solicit questions. One, at the end of this call, and then 2, we've got an email address where you can send in questions so that we can respond to you specifically. Next slide, please. So we've already covered what's available. There's the website, there are webinars, continuing education credit, technical assistance, the community that we're creating, and even within that community, there'll be affinity groups on particular areas, and then again, sharing the stories and acknowledging the great work we're all doing. Next slide, please. So the upcoming events, we're here and now on the first one, March 1st, check. You can say we've accomplished one thing here together. And again, we appreciate your being here. The April 2nd will be the reduction of early induction webinars on that specific topic in alignment with Secretary Sebelius's Strong Start initiative. May 17th and 18th, if you can't remember those dates by now, I've repeated them, I think, 8 times. That will be our in-person meeting, and would love to have at least 1 or 2 persons from your organization attend. And then beginning in June, following that May meeting, we'll have monthly topical webinars, and we will send out a schedule with the topics and the speakers. Next slide, please. So the in-person meeting in May is really foundational. And we see this as being an opportunity to provide the building blocks for change. And the kinds of things that we're going to be talking about here now, and some of them you may be incredibly well versed in, and others may be things that, geez, I'd really like to hear this person speak about this topic. And even just have the group think around what we're talking and processing. So Quality Improvement 101, you know, how to do rapid cycle change, the strategies, best lessons, and we'll have materials from Brent James and myself covering that. The business case for quality. I've been doing a lot of work with hospitals around the country talking about how can you make the business case to your organization for investing the time and commitment of staff and organizational energy on this learning journey. What are the potential savings? And we'll talk through how to sort of make that case to your CFO and other C-suite members. And then some really exciting featured speakers that we're going to have. Dr. Frank Drews is a human factors expert, and he'll be speaking at the meeting. Dr. Alan Frankel from Pascal Metrics is going to be talking about leadership and culture. And John Nance, who is a longtime aviator, we'll be talking about safety principles, and really fabulous speakers. All three of them are actually on the faculty of our advanced training program in quality improvement and patient safety here at Intermountain. Next slide, please. I'm going to try and move quickly through sort of our strategy and how we're cultivating best practices. And I will say that we're going to hold off on the questions until we really get to the end so we can try and cluster them and get to everybody's questions given the number of people on the call. But we are monitoring that as we're going, so please just be patient with that. We're really concerned about not just trying anything. And that's an important point here. We feel like there's an ethical and a moral responsibility that when we put something out as a best-in-class practice and we say, this is really where you should be investing your organizational energy, that there's some evidence base associated with it. So we're going to be looking to harvest best practices across our model delivery system partners, and those are the 7 leading delivery systems that you saw listed initially, but also through a readiness/needs assessment that we'll be sending out to you, and I'll talk to you about that in a minute. We may be harvesting best practices from your own organization based on the success stories that you have to share with us. That information will be harvested and put together on our website for you, and I'll describe how that will be organized in a moment. We'll be then doing a literature search to look at what's been reported in the literature to make sure we haven't really missed anything. And then our subject matter experts will synthesize that information, and all of that will be brought to bear in the webinars with these recommended improvements and supporting resource materials. And then on an as-needed basis, technical assistance will be offered. So that's sort of the learning journey of what we're bringing forward to you. And I think that when you look across the 26 hospital engagement networks, this is what distinguishes our hospital engagement network from the others, is that we really have the best of the best here, and we are anchored in delivery systems. We've actually done this work versus some of the groups that are just sort of picking anything that's available off websites without really screening it and looking at the level of evidence that's associated with it and understanding what are the nuances of implementing in different kinds of context or practice settings. So I hope that value is really apparent to you, that what you'll be getting will be really high quality content. Next slide, please. And at our meeting in January, you really can't read this slide, and you're not expected to read this slide, certainly. What we did was we created a systematic process so that when you look at any of the best-in-class practices that are going to be put up on our website, made available to you and discussed in the webinars, systematically we'll be providing the same elements of information. So what was the intervention? What was included? What were the lessons learned? How were leadership engaged? And what was the role of leadership in that process? Was the change sustained? What measures were used? So we'll be systematically going through all of that information so that it'll appear very standardized to you as you look through and make it easier for you to access and incorporate that information. Next slide, please. The other thing that we're doing, and again, I think this is different than the other HENS based on a meeting I was at in Chicago last Monday and Tuesday, is that we're going to try and organize the interventions that we're cataloging for you. And we're talking about 3 basic categories here. One is the basics. What should everybody be doing in this particular area? You know, for VTE or for VAP, what are the requirements? What are the just basics you should have in place? Then if you're working harder, where do you go next? And even beyond that, if you want to be ahead of the curve, where could you go? And so this will help organize the information in a way, if you know, in this area, we really need to be really ahead of the curve. It'll help you sift through that information much more efficiently. Next slide, please. And this is, I think I just learned the term correctly, a wireframe of what our website is being built out to look like. And what we're trying to do is to design it to be as user-friendly as possible. Again, it will not be password protected. And this is how you'll access content information. So there are 4 columns of information. The first is About Us, and this is where you'll get information on the partner systems with web links. The hospital map as it gets updated and more hospitals are added, and then a pledged list of the hospitals so you can see which hospitals are involved, and there may be others in your local community or in your region that you might want to know about. The recorded learning sessions is probably going to be one of the most important resource accesses for you. So again, anything that we produce, we're producing as enduring material, and it will be cataloged and accessible on our website. So for instance, this launch webinar will be there. Every topical webinar will be there. Videos from the May 17th and 18th meeting will be there. And after you finish those webinars, for example, you'll go to a CME credit survey so that we can document the completion of the training and be able to appropriately provide the continuing education credit documentation to you for your professional development purposes. In terms of additional resources, there'll be the blue shaded box is the intervention library, and that's where we're going to be putting the interventions and associated resource material. So if there is a toolkit or a checklist, those kinds of materials will all be in one place. This will be a searchable database right off of the website to make that information as easily accessible to you as possible. We'll also have useful links listed, frequently asked questions, and again, not just questions from today, but questions as we move forward in monitoring our email address that's been set up for these purposes. We'll have comparative measure information, and then finally we'll have hospital success stories that people in hospitals who have pledged to work with us have agreed to have posted. We will never post anything without your prior permission. I'm going to repeat that. We will never post anything without your prior permission. So you may say, go ahead and post this, but blind it, or go ahead and post this, but quote anonymous, for example, or we want you to say our hospital. That will be left up to you to decide. And then lastly, contact information. How do you communicate with us? And all of that information will be provided. And hopefully you'll view this website as a user-friendly portal and access to information and communication with all of us. Next slide, please. So the approach for monitoring performance is basically outcomes comparison. This is not new to anybody who's on this call, I'm sure. But what we want to do is to compare meaningful, relevant peer comparisons in our industry. Next slide, please. We've worked very hard in pledging our hospitals to try and be sure that we had adequate representation in key strata to provide these meaningful, relevant comparisons. So you can see we've got a distribution of rural and urban and by size of facility. We also have adequate representation for specialty hospitals. And it's, I think, very important. We don't want to compare results at a critical access hospital to a major referral center. We don't want to compare what's happening in a children's hospital to an adult hospital. And so we've worked very hard to create those distributions. Next slide, please. But it's dependent on you. These meaningful comparisons are really contingent on the participation of our group and our commitment to shared learning. So to the extent possible, we're trying to encourage you to work with us and share comparable measure information. A couple points I want to make about that, which I know are frequently asked questions as I've talked to many of you on the phone separately. Data will only be reported to CMS in the aggregate for our HEN. It will not even be reported at a hospital level or a system level. The exception would be success stories that you would give us prior approval to highlight and share with them. And secondly, the information doesn't go directly to CMS. There's a national evaluator, and that information goes to the national evaluator, and it's not clear to me how the national evaluator will then report to CMS. It's very likely that what they will do is they will then aggregate that data at another level and report across HENs, and perhaps provide ranges of experiences across hens, you know, the hens at the lower level versus the hens at the higher level, or what's sort of an average rate across the hens, because the national evaluator is responsible for the cross-hen evaluation. Our intent is to tie the measures to best-in-class interventions, and so not all of the measures have been picked yet. And I know people are like, well, what measures are you going to use? Well, we think it's very important to pick measures that are associated with what we're trying to change, so that you can see progress that's being made. If you pick very global, large-scale measures that aren't necessarily tied to what you're doing, for example, if you looked at all-cause readmission, but I gave you the example from Baylor where they focused on those patients with congestive heart failure. Depending on the patient mix that you have and the proportion of patients that are readmitted with congestive heart failure, you may not even see the change because it would be diluted out in that larger global measure. So we're working fast and furiously together with our subject matter experts in these 10 areas to nail down the measures. We're also waiting on the national evaluator, because the national evaluator is to give us some measures associated with the 10 areas that will be common across all of the hens so that they can do their cross-hen assessment. I will tell you that we will not pick measures that require chart abstraction. Our aim is to minimize the burden, and so to the extent possible, we're going to use what you're already reporting for other purposes. And the way that you'll submit information will be an Excel spreadsheet where we will have clearly defined numerators and denominators, and the intent is to start reporting on a quarterly basis beginning in May 2012. So I hope that helps to answer some questions that you might have about the measurement. Again, we're trying to minimize the burden on you, so until we know what the national evaluator wants, it's a little bit difficult for us to sort of finalize that measure set, but everybody is working as fast as they possibly can. The national content developer, the national evaluation contractor, and all of us as well. Next slide, please. So the question that was posed last week in Chicago was, what can we do by August 2012? And I can't hear you, but I'm guessing there's some people chuckling in the background. And there were people at the meeting like, what? You've got to be kidding. These audacious goals have been set for the end of 2013, and now you're saying, what can you do by August of 2012? Well, there are a couple reasons. One is that the Center for Medicare and Medicaid Innovation is under attack, and they need to show some results, and they need to show some results quickly. And so that's why part of the emphasis will be on success stories, and some of these things may be things that people have already undertaken and done, and so we're going to be looking to harvest some of those examples for the Secretary. Secretary Sebelius announced on February 8th, and many of you may already be aware of this, the Strong Start for Mothers and Newborns. And so one of the two foci that we're being asked to commit to now are the Strong Start for Mothers and Newborns. We're working to reduce unnecessary early inductions less than 39 weeks gestation. And there are multiple reasons for this, largely for the health and well-being of mothers and babies in our country. And this really builds on a legacy of work by the American College of Obstetricians and Gynecologists and the guidelines that they've released. And I know that there is some controversy over some elements of those guidelines. There's been the March of Dimes campaign that has ensued, and many of you, through the March of Dimes or through your state initiative, have been involved in addressing this issue, perhaps even with some of your local large employer groups. Our first webinar on the topic to report what Intermountain has done will be April 2nd, and Terry Keene, who is a leader and on the Speakers Bureau for the March of Dimes, will be the lead clinician on that. So I hope you'll plan to have someone from your hospital tune into that. And then we're being asked to identify a second early focus. So out of those 10 things, what would be a second area? Now, anybody who's worked with me knows that I am very much opposed to sort of a dictatorial, authoritative approach in moving forward. And as I said earlier on, we're trying to work with you in partnership. And so to the extent possible, we are going to try and identify the second early focus by the responses that we receive from you to the readiness and needs assessment survey that we'll be sending out to you this coming Friday. So your attention to that and your completion of that in a timely fashion will be really important, and it gives you an opportunity to help shape how we move forward. Next slide, please. So we want your input, and again, I can't emphasize this enough, we're trying to design a program and provide support with and for you. We want to help elevate us all as we're trying to achieve these goals. The readiness and needs assessment will be coming on March 9th, and we're asking that you return it to us by the 16th of March. Over the next week and a half, 2 weeks, you will be receiving a call from Dr. Bruce Bailey, who is our evaluation director, or one of his staff persons, who will be following up with you to have a more personal discussion about you. What are your issues? What are your concerns? What are your questions? How can we help you move this forward, in addition to just sort of your standardized answers on these survey forms? Because again, we want to solicit your input and your engagement in this process. And I would really like to encourage you to think about the boldness of your commitment. Next slide, please. This is a quote from Helen Keller that I really like, and I tend to use a lot, but I hope it's the spirit of us moving forward together. Alone we can do so little, and together we can do so much. And the opportunity that we have to really lean on each other, learn from each other, I think is a tremendous opportunity, and the fact that we've even gotten this far on our journey is a tremendous achievement, that all of our hospitals have come together and said, yes, we want to work together on this. Now we've got to figure out at what level of commitment, and so I would urge you to be as bold as possible and to be as willing to share as possible. And with that, I think anything is possible. Next slide, please. So these are the primary program support staff, and I hope these names will become familiarized to you because you will see them. Again, I'm Lucy Savitz, and I'm the program lead. Jason Scott, many of you have probably already communicated with him, is our program manager. Amy Wuthrich is our education coordinator, and Bruce Bailey is the evaluation director. And we've got two tigers. Now, I don't have to defend CMMI's choice of hens and tigers, and who knows what animal will come next, but to explain very briefly, tigers are implementation experts, and we have two that are working with us on this project. Troy Larkin is based at Providence Health and Services, and Chris Schutz is based at Baylor Healthcare System. And I met with them last week on Thursday and Friday. They're really wonderful. They've been doing this work for many, many years. They have almost 25 years of combined experience in this area and worked on all sorts of different implementation efforts, as well as other members of our team. And I'd also like to acknowledge Squishy Media. You see the their website here for all of the media support services. And I will tell you, it may seem like it's a slow start getting our website launched, but everything has to be something that's called 508c3 compliant. And it's been a major hurdle for all of the hens. And so we're working as quickly as we can to get tools and resources and materials compliant so that we can populate the website for you. And that will be coming as soon as possible. As soon as we start getting the database up and running, we'll be sending out an alert to you so that you won't have to constantly go back there and check. But know that we are working quickly to try and do that, and we've got great support in this team. Next slide, please. So again, I can't tell you how much I thank you for being willing to work with us. There is a one-page sort of stand-up of our website that you can go to now, and the address is here, henlearner.org. If you have email questions on anything, you can just email admin@henlearner.org. and we'll respond to you as quickly as possible, hopefully within 48 hours at the latest. So we're willing to work with you. We're happy to work with you. And I'm going to stop there and see if there are any general questions. Jason?
Yeah, we have two that were posted online, so I'll just read those. First, what does technical assistance entail?
Okay, technical assistance is really an amorphic term, and it really is something that we will provide on an as-needed basis. So, for instance, if you're trying to implement a change in your organization and you're not sure how to implement that change into a standardized workflow process, one of the things you might be interested in is, well, you know, if the best-in-class practice came from Denver Health, a safety net provider, what did they do? How did they overcome this particular challenge? We'll be able to get that information to you and hopefully make that personal connection. If you're having issues about how do you mobilize and motivate a team and keep them engaged and focused versus a sort of one-shot kind of deal, that's the kind of thing that Troy and Chris can really help you with. I'm sorry, who's speaking, please? Hello? Brian, I'm not sure we're supposed to have the lines open right now. And Jason, you had a second question?
Yeah, the second question is my understanding that the work product will be provided from the national content developer. However, it sounds like Intermountain intends to harvest content from the hospital participants. Please clarify the role of the national content developer.
Okay, so our hen is different than the other hens. Most other hens don't have the means to generate their own content, and so they are relying on the national content developer for their content. And the national content developer is using all sorts of means to collect things. They're going to websites. They're going to federal agencies like the Agency for Healthcare Research and Quality. They're doing literature searches. They're just pulling things from wherever they can find them in both the peer-reviewed and the gray literature. Our hen is different. Our content is coming primarily from the 7 leading delivery systems that we reviewed with you at the very beginning, and through the process that I described briefly to you on this call today. In addition, as I mentioned, we'll be asking you for success stories that you have in your own organizations and may do follow-up calls with you. Maybe you're doing something and have done something that has eliminated a particular adverse event in your facility. We would like to know about that, and we would like to bring that into the shared learning. So we're using delivery systems, solutions that are evidence-based. We will, again, also look at the literature, but I think what you're getting from us is a higher level of content quality. Are there other questions, Jason?
There's none posted online.
Brian, if you want to, I don't know if people have raised hands, if we could open one line at a time if you see somebody indicating a need to ask a question. I can see people going on. I would just want I know. We probably don't want to open all lines simultaneously. Are we seeing anything else? I know sometimes, you know, when you sit through one of these webinars, you think, oh, that's clear, I understand, or maybe I have to go back and talk to somebody in my organization so I can really formulate my question. You do have our website, which could we possibly go back to that last slide so that it continues to appear on how to contact us? Not that slide, the last one, that one. So if you do have questions following this call and you think, wow, I wish I would have asked this question, or maybe I didn't get a complete answer to this and my boss is asking me this question now, please don't hesitate to email us, and we will be monitoring that email. The other thing that we'll be doing is trying to assemble a list of frequently asked questions as questions are being posed, so you can see the kinds of things that other people are asking as well. So let me just pause here a minute. If we could please just leave the contact slide up while we're waiting for questions to be posed. We're having trouble, a technical issue that we'll solve before the next call. I don't want to open all lines simultaneously because everybody will be talking over each other and some people will be having independent conversations. If you could type in your question, that would be very helpful. Let me just pause a moment and see if anybody has any last questions that they would like to pose here now by typing those in. Other questions, Jason? Okay, well, I'd like to say that we will. Oh, Cecilia, you've raised your hand. Do you have a question? Brian, why don't you open the lines, and if everybody could just either be on mute or quiet while Cecilia asks her question.
Can you hear me now?
Yes.
Okay, great. So I have about 3 questions. The first one was, how do you decide which 10 people get the CME when you offer CME?
Your choice. Okay, why don't you go ahead and ask me all 3 questions.
The second one is, how do you identify different levels of learning for the different areas? Because the form, as I recall, just asked you to identify your level of learning. It didn't give you an option of saying different levels for different areas.
And your last question?
And then the third question is it possible to attend the in-person meeting or the webinars without committing to active or engaged learner levels?
Okay, let me take those 3 questions in order. And Brian, if you could just mute the line so we could have quiet while I answer. Thank you. So which 10 people, and you actually may get more than 10 slots because depending on how people end up pledging, we may be able to offer more than 10 slots to your particular hospital. And I would say that that's 10 slots by hospital, not 10 slots by system. And that would be up to you to decide who you would want to pick. And I don't know, I would not want to superimpose my thoughts about how you would choose to do that in your own organization. I would probably guess that, you know, if you pick areas of, you know, sort of active or real-time learning, you would want to identify, you know, those people who are going to serve as your clinical champions. One of the things that we're going to be sending out to you is how to sort of cluster these areas. So there are certain adverse events on the list that are more alike than others. So for instance, those things that happen at the bedside, those things that are infection related. And so I would try to identify clinical champions in those sort of clustered areas and make them a priority. In terms of the identified levels of learning, you must have gotten the initial form. I'm not sure what form you got because we haven't asked anybody to pledge their level of commitment yet. The purpose of this call is to explain the levels of learning and explain the flexibility in declaring what level of learning that you want to pick, and that you don't have to pick one level of learning for all 10, that there is flexibility that's involved. And so I would like you to be thinking about that, and we're asking you to make those commitments known in response to the Readiness Needs Assessment Survey that will be sent out on March 9th, and we hope you will return by March 16th. So that you have time to process this, go back to your teams and think about it, and make more of a group decision about it. So all we've asked people to do thus far is commit your hospital to pledge to work with us. You can only work with one hospital engagement network. And that now it's the time to pick the level of learning. And then Cecilia, your third question had to do with, is it possible to send people if you're just passive learning? We could accommodate that on a space available basis, but would prefer to make room for active and real-time learners at the in-person meeting. Passive learning, as I said, all of the Enduring materials will be available on the website, so we will be making videos of what's offered here in May. And you could still be, you know, an active learner, but decide, I just can't get there on May 17th and 18th. My child is graduating from college or something like that. Those materials will be available. We're trying to be as flexible as possible and as respectful as possible to the other commitments that your organization has. Does that answer your question, Cecilia? Brian, can you open the line?
Yes, thank you.
We had 2 more questions come in online. The first one is, will you remind us where we can access a copy of today's presentation?
Okay. You will be able to access a copy of the presentation at henlearner.org, but we can't put things up there until they're 508c3 compliant. So in the interim, because we know that you're going to need to talk to other people in your organization, after this call, we're going to send you a copy of the slides. Anything that goes on our website has to be 508c3 compliant. And I don't mean to portray this as a bureaucratic burden, because it is important that we make materials available to all people, particularly people with disabilities. So we consider that an important action step, but we're trying to get the information to you as quickly as possible. The other question, Jason?
Okay, the other question is, the Strong Start program is not one of the 10 areas of work originally included. Should we expect further expansion of the scope of work?
Yeah. The Start Strong project is considered under the OB trauma area, which is one of the 10 areas. And so it is not viewed as a change in scope of work. Okay, so we've got about 1 minute to 2. That's all of the questions we've received. So please be reminded, if you have additional questions, we're happy to answer those questions. I hope you will be bold. I thank you for working with us, and I think we have a lot of important work to do. So take care. We'll be in touch soon. Thank you very much.